I'd like to thank IOS for giving this opportunity to speak in front of you. I'll be speaking on imaging in neuro-ophthalmology, the financial disclosures slide. And once or quite frequently you might have an instance that I should not have ordered this imaging, I should have ordered a contrast imaging, or I should have ordered a MRI instead of a CT. It's not infrequent that you end up with such a situation. So the choice of correct investigation at the right juncture is one of the most important and crucial steps in a patient's management, especially in a developing country like India, where the people cannot afford a CT, MRI and a contrast enhanced MRI one by one. We have to actually tailor our investigative modalities to the best one, so that we can pick up the pathology at the first go itself. So as you know, there are various modalities for picking up the pathologies in our neuro-ophthalmological cases, the simpler one being the X-ray, USG, the color Doppler, MR and the CT scans, and of course the MR angiography and the CT angiographies. So a basic approach to a neuro-ophthalmological case, you should have the following things in mind when you start off. You should have a presumptive diagnosis based on the clinical features, and secondly you should have the location of the lesion, so that you can ask for the particular area where you need the imaging to be focused on, whether it is an orbital lesion or an intracranial lesion, most importantly. The third part is what is the characteristic of a lesion, whether it is an inflammation, whether it's an infarct, whether it is a mass lesion which you are suspecting. So depending on that, you can tailor your investigations. And finally, you should be able to correlate your findings, clinical findings, with the imaging findings which you have got. And that will help you as a neuro-ophthalmologist to end up in a correct diagnosis and localize the lesion. So beginning off with the simpler ones, the first one I would discuss about is the X-ray. X-ray, as you know, has limited utility nowadays, but of course it is one of the best and the simplest techniques by which you can find out the lesions if the patient has had a trauma or you're suspecting a foreign body inside the orbit. So, and the most common X-ray views which you order as an ophthalmologist might be a PA view or a lateral view, but I would like to take you further into it. There are various views which you might be knowing and which we have learned all through this days, like there are Waters view, there is Calvel view. As you can see in this picture, this black line represents the X-ray film, and the CR represents the central ray of from where the X-ray is being projected. So the patient is aligned in such a way that his chin touches the X-ray film in a Waters view, and this Waters view is usually done to find out if there is any fracture of the floor of orbit, and especially to be specific, it speaks out the floor of orbit in the anterior two-third of the orbit. So similarly, you can do a Calvel view or a lateral view or a basal view. But more importantly, which I would stress over here, is the Reese position or the X-ray view, where you can see the optic foramen. This is an X-ray of the patient which has been done in the Reese view. So you can see this A, which I have noted as A, is the optic foramen, where you can see the optic nerve passes through this. This area which is marked as C is the superior orbital fissure, which is separated from it by an optic strut. Now, if you have a lesion, you are suspecting an optic nerve lesion like a meningioma or an optic nerve glioma, you might find an enlargement of this optic foramen area, and you can compare the other side and can probably suspect a pathology. Or otherwise, if you are suspecting a trauma and a fracture of the optic canal, probably you can pick up that in this one of the simpler techniques. So these are the various positions, various projections which you can do while you are doing an X-ray. The one is the Waters view, which I told you already. It's a blowout fracture. It picks up the fractures in the anterior two-third. And if it is a posterior one-third which is being involved, you can do a Calvel view. And the last one, the more important, is the Reese position, where you can see the optic canal, and it will help us to pick up the optic nerve tumors and optic canal fractures. And another one which I would like to tell you is about the lateral view. As I had mentioned here, it can pick up pituitary disease, because if the sella turcica is enlarged, you can see that view on that lateral view. You might be able to see the sella turcica, and if there's a mass lesion which is sitting over there and it has enlarged the sella, you can pick up it on the simpler X-ray itself before going into an CT scan or an MRI. Now, this is another simple modality which is usually most commonly done nowadays, is ultrasonography. And one of the most important advantage of this is that it is a non-invasive technique and it is a non-ionizing technique, and so thus we don't have any of the complications of the ionizing radiations. It can be done in a child also, it can be done in elderly people also. and it is basically based on the principle that the various tissues reflect the ultrasonic waves, and then it is picked up by the transducer and it is projected into the B-scan picture where you can find out the lesions. And it can be mostly used for the intraocular lesions and the orbital lesions. And nowadays, by the high resolution probes which are used in ultra UBM modalities, you can even pick out lesions which are quite anterior. Now, the next third modality which I would speak about is the CT scan. First of all, you should understand what is a CT scan, how does it work. There is an X-ray detector and there is a collimated source of X-ray. So it is basically an modality is just like an X-ray, but the speciality in this is that the whole X-ray detector and the collimated source of X-ray moves around the patient, and it creates an image which is taken over by the computer, and it is formed into a 3D image. Now, what happens is that the X-ray, when it passes through the body, it is being attenuated by the different tissues, and depending upon the amount of attenuation which is present, for example, if you take bone, it attenuates the X-ray much more larger than the other soft tissues, so it will create a much more very good picture in a CT scan. Thus, CT scan can be used especially for bony injuries or foreign bodies. Now, what are the most common sections which we take? We usually take coronal slices which are 3 mm or less in size to find out if there is an orbital lesion, and bony reconstructions can be done after a CT scan is being done. What is the use of a contrast in the CT scan? Contrast enhanced CT scan, or the CECT, is usually used to detect if there is an intracranial extension of any orbital tumors, or to evaluate a chiasmal and parachiasmal lesions, or if there is a cavernous sinus lesions. When should we use it? If you are suspecting increased areas of vascularity, that is the area where you will find the contrast is going to work. Or if there is areas of blood-brain barrier breakdown, that is a region where the contrast might be working. The other cases, the contrast might not give you much help for the diagnosis. Now, as I have told you, the CT scan has various advantages and it has disadvantages. The main being that CT scan is cheaper than the MRI, it is fast, and it can be used definitely where MRI is contraindicated. MRI is contraindicated whenever there is a foreign body inside your metallic foreign bodies inside your body. If you have used any pacemakers, any clips, then we should not do an MRI. But in that cases you can opt for a CT scan. But definitely CT scan has various disadvantages also, because it uses radiation and you cannot repeat in small children again and again to find out what is the progression or what is happening to the tumor mass. Now, understanding an MRI, MRI I would say is like the patient is put in a big MRI machine, and MRI machine is like a school teacher which aligns all the protons inside the body in a single direction. It aligns, makes it all parallel to each other. So in our body there are multiple protons which are present inside the water content, and these protons, all the protons are aligned in one direction. It becomes parallel, and once after they have been made parallel by the magnetic field, then what is done is that we are giving a radio frequency pulse on that, and as the radio frequency pulse is being given, it's like external force. Two things can happen. Either children will become all dispersed out, so they can become anti-parallel, or that it can become all synchronized. So there are two things which takes place. One is that all the protons become anti-parallel, and then it is called as longitudinal magnetization, and or else what happens is that all becomes synchronized, and that is called transversal magnetization. Now, what happens? What is the importance of knowing all these things? What is longitudinal magnetization? Well, it is otherwise what you call as T1 weighted images. So what happens to the longitudinal magnetization is that when the RF pulse is switched off, the longitudinal magnetization which is present, it increases. That means it again becomes parallel. So when it becomes parallel, it is from a high energy state to a low energy state, and that is picked up by the MRI machine, and it is shown as a T1 weighted image. When the synchronization is lost, it is called as transversal magnetization is decreasing, and that is called as a T2 weighted images. And T1 weighted images helps us to find out what is the tissue composition, and T2 depends on the external and internal magnetic fields. Now, this is a basic chart which you should have in mind before assessing a MRI. So, one main thing I would like to stress over here is what will the water look like? It will look like dark in the T1 and bright in T2. We used to learn a mnemonic which is still used at many places, World War II. Water is white on T2, World War II. So, water is bright, and CSF is also bright in T2. These are two things which are very important over there. And gadolinium appears bright in the T1. Air is dark in both the cases. Now, these are the special sequences which you can order when you are doing an MRI. The two main things which I would like to stress over here is the fluid attenuated inversion recovery. It is also known as the FLAIR sequence, FLAIR, FLAIR sequence, and the second is the FAT suppression. FLAIR sequences are usually used to find out if there is a lesion in the periventricular area in multiple sclerosis patients. So at certain points you might be having a difficulty in finding out whether there is a periventricular plaque in a multiple sclerosis patient, and in such conditions what you can do is that you can order for a FLAIR sequence wherein the CSF will be completely suppressed. The CSF picture which would be appearing white or bright in a T2 scan will be completely suppressed, and you will be able to pick out if there is any periventricular plaque. The second thing is a fat suppression, which is usually used to find out if there is a pathology in the orbit or in the pituitary or in the skull base. Because if the fat is bright in T1, I had shown in the previous slide, the fat is bright on T1, and if there is a lesion inside the fatty area of the orbit or in the pituitary base, then it might get masked by the brightness of the fat. And if you can suppress that fat by these two techniques, which are called the short temporary inverse recovery and the chemical based recovery suppression, then if these two techniques can be done, we can suppress the fat and we can identify the pathology which may be masked. I think I can take a little more. So these definitely, as I told you, in CT we can use contrast also in MRI. What happens while you are giving a contrast? The common contrast agent which is given is the gadolinium. Gadolinium is a toxic agent. It is usually combined with DTPA to give it as a contrast agent inside the body, and once it is given, it will shorten the T1 relaxation time, and it is used to find out whether the lesions are getting enhanced on the T1 image. So one point I would stress is that usually the contrast agents, whenever you are looking for a contrast image in an MRI, you are looking in the T1 phase. It's not the T2 phase, it is the T1 phase where you give the contrast agent. And every investigative modality has advantages and disadvantages. This also has disadvantages, that it takes more time and it is difficult in a claustrophobic patients. It is difficult if the metallic implants are present in our body. So if it is a small child, it might be difficult for the child to lay there for a long time while doing the MRI. Now, which modality should we use and when it is indicated, and whether contrast or no contrast should be ordered? This I will be able to make you understand by telling you about a few clinical scenarios. These are the few indications where we will order for MRI and CT scans. The simpler one I would begin with is the USG, where you can see it might be easy to pick up a cysticercus cyst or intraocular retinoblastoma or a melanoma by using a USG. In neuro-ophthalmology, you might find these conditions. This is basically an optic nerve head drusen, which can be picked up on the USG as a high reflectivity which is present in the optic disc area. This is the USG, this is the vitreous, and this is the optic nerve head and optic nerve following behind that, and this shows the high reflectivity of the optic nerve head, showing that it is the optic nerve head drusen. In conditions where you have opaque media and you are suspecting papilledema, so you are not able to see the disc. Suppose it was a old patient and the patient had almost a mature cataract and you are not able to see the disc. Probably you can pick up papilledema, the disc edema, on the USG itself, which shows that elevation of the disc is present. The second modality is a CT scan. As I have discussed, CT scan is best for fractures, acute hemorrhage, and foreign body, and in thyroid ophthalmopathy. In these conditions, you can do away with a non-contrast CT. So, if a patient comes to you after a trauma, you don't have to order a contrast enhanced CT. You can directly go for a non-contrast CT scan in such conditions. This shows a fracture of the optic canal, and this picture shows the muscle bellies are thickened in a thyroid ophthalmopathy. This is again a trauma patient with a trauma which shows an inferior orbital floor fracture with all the orbital tissues protruding into the maxillary sinus. This is a contrast enhanced CT, and this will show you how the contrast helps in a CT scan. This was a patient with pituitary adenoma, and you can see it is very ill defined in a NC-CT scan. Now, if you're suspecting such a lesion on a GVF chart, you have got a chiasmal lesion, you're suspecting a chiasmal lesion, then I think we should go ahead with the CT scan, so that you can pick up the pituitary adenoma and the perilesional enhancement which can be seen after giving the contrast. Now, in MRI, when should we order for a contrast? MRI, you can order for a contrast in if you're suspecting optic neuritis, if you're suspecting optic nerve gliomas or optic nerve meningioma. This is a patient MRI of a patient with optic neuritis. These are the T1 images. As you can see, the vitreous is black in both the conditions. Here also it is black. Both of them are T1 images. But definitely, we had suspected optic neuritis in this patient based on the clinical findings. And as you can see, what is the difference in the after giving the contrast? Gadolinium contrast was given, and you can see that there's a definitive enhancement of the optic nerve up till the chiasma. So it shows that even you can pick up much more clearly on the contrast-based MRIs. Now, MRI with contrast can also be used for pituitary gland tumors, a suprasellar mass, an intracranial extension of orbital mass, etc. Now, this is a patient MRI scan with a T2 weighted image, pre and post contrast. You can see this was a sellar mass which was present, which is quite visible, but definitely it is much more better visible on a contrast scan in the T1 weighted image. Now this is a MRI scan of a normal patient actually. Patient didn't have any ocular pathologies which we had suspected, but definitely you can see that this is a T1 image where you can see that the fat is completely enhanced. But here, after suppressing the fat, you can clearly identify the various structure. You can identify the optic nerve, you can identify the muscles, you can identify the extraocular tissues. So, fat suppression is one of the methods by which you can find out if there is a lesion on the orbit. This, as I told you, is a flare sequence. Flare sequences are usually used to find out whether there are periventricular plaques. So here, as you can see, this is a T2 image, but the CSF has been suppressed. And after the suppression of CSF, you can definitely pick out the periventricular lesions. So MRI is usually superior to most CT in picking out most of the intracranial lesions, but definitely CT can be useful in finding out lesions like acute hemorrhages. CT and MRI angiography is usually used for finding out any intracardiac aneurysms or posterior communicating artery aneurysms. CT angiography is minimally invasive, and it can be done by assistance of a computer. You can make a 3D images of the various medium and small sized arteries. This is a picture of the CT angiography which has been done for a posterior communicating artery aneurysms. And MRA, similar to the CT angiogram, MRA can also be used to find out if there is any aneurysms. You can do it either with the contrast or without the contrast. Without the contrast, there are two sequences which you can use. One is a TOF sequence or time of flight sequence, and this other one is a PSA sequence, that is phase contrast sequence. So you can use these two, which are done without a contrast, but you can of course take help of a contrast agent like gadolinium. So there is a sequence called gadolinium enhanced MRI. So you can do that also to find out if you're suspecting an aneurysm. And definitely after doing this, you can do a digital subtraction angiography, which is considered the gold standard for picking up aneurysms. So this is the case with the MRI has been done for the carotid arteries. And final thing which I would like to say is newer techniques which are functional MRI imagings, where hypermetabolic areas and hypermetabolic areas can be picked up on the MRI. To conclude, this is a small chart which I have piled up all the topics which I have covered now. One of the things is that orbital tumors, you can use USG or a non-contrast CT. If you're suspecting a trauma, you can use a non-contrast CT. But definitely if you're suspecting an orbital apex tumor, then you should go for a gadolinium enhanced fat suppressed MRI. And if it is a acute hemorrhage, I think you can go ahead with a bright CT scan where you can find a bright lesion. And if it is an aneurysm, you can go ahead with an MRA, and after that get a digital subtraction angiography. If it is a multiple sclerosis, you should go with a flare sequence. Papilledema, you can go ahead with a USG or a gadolinium enhanced MRI or a MR venogram. If you don't get findings in any of these, probably you can go ahead with an MR venogram to find out if there is a sinus thrombosis. And to conclude, whether we should decide first of all whether we should do a CT or a MR scan. And most of the conditions, as I have told you, is MRI is superior to the CT scan in most of the indications, but definitively CT is better in these four conditions. One is when there is calcification, one there is a bone injury, one when there is an acute hemorrhage, and when MRI is contraindicated. Contrast is not necessary in acute hemorrhage, in thyroid ophthalmopathy, and in trauma. Localize the lesion clinically and study tailored to the location. You can order for special sequences like fat suppression in orbital studies. You can order for a flare sequence when you are suspecting a white matter lesion, or you can order for a diffusion weighted image when you are suspecting an infarct. Thank you.